The title hangs in the air like a question women have been asking their bodies for decades. What is PCOS, and why are so many women being diagnosed? Polycystic ovary syndrome is not a single disease, not a neat villain you can point to on a scan. It is a pattern, a constellation, a storm system that settles into the endocrine landscape of the body and quietly reshapes it. Hormones, those microscopic messengers that dictate hunger, mood, fertility, metabolism, begin to speak over one another. Signals cross, feedback loops fray. What should be rhythmic becomes erratic. At its core, PCOS is defined by three features: irregular or absent ovulation, elevated androgens, often called male hormones, though every woman has them, and ovaries that may appear polycystic on ultrasound, not true cysts, but follicles paused mid-development, like breaths held too long. You don't need all three to have PCOS, you only need two. That diagnostic flexibility is both a gift and a curse. It allows more women to be recognized, but it also means PCOS can wear many disguises. For some, it arrives loudly: unpredictable periods, acne that resists every treatment, hair thinning at the scalp while coarse hair grows on the chin or chest. For others, it is quiet and metabolic: stubborn weight gain, crushing fatigue, blood sugar that spikes and crashes, insulin working overtime just to be heard. For many, it shows itself first as infertility, a devastating silence where ovulation should be. Same syndrome, different lives, different costs. PCOS is not rare. Depending on the criteria used, it affects somewhere between 8 and 13% of women of reproductive age worldwide. In some populations, the number may be higher. Yet, for most of modern medical history, it went largely unnamed, misunderstood, or dismissed. Women were told their symptoms were cosmetic, emotional, self-inflicted. Lose weight, relax, it's just your hormones. As if hormones weren't everything. So why now? Why does it feel like PCOS is everywhere? Part of the answer is visibility. Diagnostic criteria expanded in the early 2000s, acknowledging that PCOS does not look the same in every body. Ultrasound technology improved, blood tests became more precise, women began talking to each other, online, in doctors' offices, with a clarity and volume that could no longer be ignored. What once hid in the shadows of underdiagnosis stepped into the light. But visibility is not the whole story. PCOS has deep biological roots. There is a strong genetic component. If your mother or sister has it, your risk is higher. Yet genes do not act alone. They respond to environment, to nutrition, to stress, to the metabolic world we now inhabit. Insulin resistance plays a central role for many women with PCOS. Cells stop responding efficiently to insulin, so the body produces more. High insulin levels stimulate the ovaries to produce more androgens. Those androgens interfere with ovulation. The cycle feeds itself, a hormonal feedback loop locked in overdrive. This is not about willpower. This is physiology. And the modern world is an aggressive place for that physiology to exist. Highly processed diets, chronic psychological stress, disrupted sleep, sedentary routines, and constant light exposure all press on the same systems that regulate insulin and reproductive hormones. None of these factors alone cause PCOS, but together they can amplify an underlying vulnerability, turning a predisposition into a diagnosis. There is also growing concern, carefully studied, still unfolding, about endocrine-disrupting chemicals. Compounds found in plastics, pesticides, cosmetics, and industrial waste can mimic or interfere with hormonal signaling. The evidence does not allow simple blame, but it raises unsettling questions. What happens when developing bodies are bathed from the womb onward in signals that confuse the endocrine system? What patterns emerge decades later? PCOS may be in part a mirror, reflecting back the cumulative strain we place on hormonal biology. And yet, there is another reason diagnoses are rising that has nothing to do with pathology at all. Women are staying in their bodies long enough to notice. They are delaying pregnancy, tracking cycles, questioning symptoms that previous generations were told to endure in silence. Infertility clinics, where PCOS is one of the most common findings, have become diagnostic gateways. A woman may live half her life without a name for what her body has been doing, only to receive one when she tries to conceive. That delay can feel cruel, but it reveals something important. PCOS does not suddenly appear. It evolves, it adapts. It has likely been there for years, shaping energy, mood, metabolism, quietly influencing risk for type 2 diabetes, cardiovascular disease, and anxiety long before anyone said the letters out loud. This is why the question matters. Not just what is PCOS, but why are we seeing it now? Because the answer lives at the intersection of biology and culture, genetics and environment, medicine and history. Because PCOS is not merely a reproductive disorder, it is a systemic one, touching nearly every organ that listens to hormones. And because for millions of women, the diagnosis is not just clinical, it is personal. It reframes their past and casts a long shadow forward. It asks them to renegotiate their relationship with food, with fertility, with femininity, with time. It demands vigilance without offering certainty. PCOS is not new, but the world around it has changed, and women, finally, are being allowed to name what their bodies have been surviving all along.